Okay, so welcome to the third session. So Mark Turner and I will be moderating this, and I think we'll move straight on to the first talk. I think Joseph's available. Joseph Vettukattil is a colleague of ours, used to be in Southampton and now in Michigan in the United States. And Joseph's going to talk to us about the flow restrictor device and indications for patients with heart failure and pulmonary hypertension. Joseph, are you? Yeah, I can see you. The floor is yours.
Thank you. I hope you can see my slides.
I can. No, we can see you, but not the slides, Joseph.
Oh, I have shared the slide, but I don't know how to share it in case.
There should be a green bar at the bottom.
I'm pressing it, but nothing seems to be happening.
Have you got?
Otherwise, Joseph, Magda might, if you've sent the slides, Magda can do it from this end.
Yeah, fortunately, I don't have slides of Dr. Vettukattil.
Oh, I see. Thank you.
Magda, do you want to see if Joe needs rights to actually share?
That's probably what it is.
He's one of the panelists. He should be able to share his slides.
Do one thing. Why don't you go with the next talk? I will.
Okay. So that's fine because Matt is on the line. Is Matt ready? Matt Jones?
Yeah, I'm here and good to go.
Hi, Matt. Matt, we'll go with you because obviously it's a very similar talk. So Matt, if you give your talk on other indications.
Joe's up. Joe's up. You can see it.
Okay, away you go, Joseph.
Stand down.
Thank you, and very much for inviting me to give this talk. My presentation is on indication for atrial flow regulation in left heart failure and pulmonary arterial hypertension. I will try to finish my talk in next 10 minutes with discussing the concept of atrial flow regulation, and then touch upon the uniqueness of AFR device and then its application in pulmonary arterial hypertension and left heart failure. So the concept of atrial decompression is known to us for some time. It is to achieve a controlled flow between systemic and pulmonary venous circulations in some complex congenital and acquired heart diseases, as in diastolic heart failure of the right ventricle, exemplified by the pulmonary arterial hypertension, where the cardiac output and effort tolerance is improved at the expense of acceptable desaturation by improving oxygen delivery and by creating atrial communication. In left heart diastolic failure, the symptoms of heart failure due to pulmonary venous congestion is relieved by decreasing the cardiac output. So usually what we used to do was either do a balloon septostomy and followed by stenting, but the main problem with balloon septostomy was to achieve a controlled flow was rather difficult, and often spontaneous closure was present later on. Stenting was a better option, but again, stent occlusion and stent migration is a common problem. And moreover, getting a predefined accurate fenestration size was almost impossible with a stent. So once we decided that it is better to have a dedicated device, the question was, what is the appropriate shunt for these patients? And in the left heart failure, there are initial or preliminary data suggested that an 8 millimeter shunt may be what is required. And this is from at least 3 studies, which is published, including a computer model. But in the setting of pulmonary arterial hypertension, it was much more not well defined. So we worked with Michael Broom from Karolinska Institute in Sweden and looked at the various fenestration diameters at various resistances and pressures between the atrium. And then it is quite evident from the graph that by the time you reach about 15 millimeters, the flow becomes unrestricted and the QPQS cannot be augmented any further after you reach about 2.8 times pulmonary blood flow. And the atrial and pulmonary both atrial pressures come to almost the same by the time you reach about 15 to 16 millimeters. So this was used as the basis for selecting and developing multiple fenestration sizes, and depending on the left atrial and right atrial pressure and the resultant saturations, we came up with this algorithm of 6 to 10 millimeters for getting a predefined accurate cardiac output based on existing resistances. So the unique feature of AFR is that you have different fenestration sizes that balance the hemodynamic more precisely for the patient profile. There is a variation in the device waist that accommodates the thickness of the atrial septum and the angulation of puncture, sometimes causing longer than the septal thickness itself. The ease of deployment and retrievability is very unique to AFR device compared to others, and the ease of demonstration on follow-up on echocardiogram. Other important aspects are, apart from the variation in sizes, the delivery system is a proven system with a more reliable release mechanism and smaller sheath and less metal load for AFR device compared to Covia or V-Wave devices. Now we have about 48 different devices available based on the fenestration size ranging between 4 to 10 millimeters at 2 millimeter increment. And you have waist sizes of 2 millimeters, 5 millimeters, and 10 millimeter thickness. And the French size for delivery is between 8 and 14 millimeters. So as we discuss, the main mechanism of action in pulmonary arterial hypertension is one, by augmenting the cardiac output by increasing the preload of the left ventricle at the expense of desaturation, but the desaturation does not affect the oxygen delivery because the cardiac output compensates for the tissue distribution of oxygen. There is decrease in venous hypertension and venous congestion. There is improved coronary perfusion because you are reducing the RI pressure and thus the coronary pressure gradient, and thus improving ventricular function. There is improvement in organ perfusion in general because of decrease in the systemic venous pressure. And in every cases there, the AFR was deployed, there was complete resolution of syncope or near syncope in these patients. So indications for AFR in pulmonary hypertension are after optimal medical therapy. If there is progressive symptoms that is currently used, this may change. We have used it as a bridge to transplantation or to wean off patients from ECMO. Symptom relief of syncope or P-syncope. And there are some questions which recently raised. Does that underlying condition that causes pulmonary hypertension matter in the placement of AFR device? And the general answer is no. But in case of parenchymal lung disease, where there is significant oxygenation and carbon dioxide diffusion problem, this may be a contraindication because underlying saturation, baseline saturation should be at least above 90 to achieve a significant improvement in cardiac output. The other question was whether RI pressure matter because there was absolute contraindication for using balloon septostomy if the RI pressure was more than 20. Now we have at least 5 to 6 patients where we have used it in up to 25 millimeters of mercury of RI pressure without any problems. And also what is important is that these patients can be diuresed and given inotropes if necessary pre-procedure so that RI pressure is not that high and there is no acute decompression in these patients. Another issue to consider when you put an atrial flow regulator in the atrial septum, when you are causing desaturation acutely, you say, suppose saturation goes to about 87 to 86%, then your expected hemoglobin concentration would be about 16 to 17 in them. And my preferred option is to give pack cells peri-procedurally because I learned it in the first patient where I had significant desaturation and she remained symptomatic. And it was all that I created acute anemia, relative anemia in this patient. And with pack cell transfusion and getting the hemoglobin about 16, there was significant symptomatic improvement. That's one thing to keep in mind. This was my first patient ever to receive AFR device in 2014. This is a patient who had severe anasaka with heart failure and was refused or not considered suitable for heart-lung transplant. And she had hospitalization for 2 weeks, intravenous diuretics and inotropic support. And then we made the custom-made AFR for that patient, and with FDA approval, we had the device put in. And 1 year later, she was suitable for transplant, and she received a heart-lung transplant. She's alive and well now. If you look at the overall history of AFR in pulmonary arterial hypertension, initial experience was from Shivakumar with 12 patients, and you can see there was significant improvement in NYHA class, syncope complete resolution, improvement in 6 minutes walk test, and significant decrease in oxygen saturation appropriate for the desired cardiac output. A larger study with compassionate use patients from 7 international centers by involving 35 patients, we showed that there is persistent result in all these patients. There were 4 deaths in this group, all due to very severe progressive pulmonary arterial hypertension in 3. 1 was unrelated to underlying heart disease. Shiv Kumar again published more recent data in 39 patients, again confirming that there is symptomatic improvement in all patients, 100% relief in syncope, and appropriate decrease in oxygen saturation and reduction in RA pressure with increase in cardiac index. This is the expected versus observed survival in pulmonary arterial hypertension, and you can see that the dark line above shows the survival in patients that was observed in this 39, whereas other lines show the expected mortality in these patients. Coming to AFR in diastolic heart failure, it is to cause atrial decompression, the left atrial decompression, by decanting the flow into the pulmonary vein that is reversed because of diastolic pressure, especially with exercise, into the right atrium, so that you are reducing the cardiac output, but symptomatic relief is provided for this patient. The first study for AFR, it was in RELIEVE trial, which was a prospective non-randomized pilot study to assess efficacy of atrial flow regulator in both patients with mild to moderate reduction in ejection fraction, as well as those.
We're into the last minute, so if we can just ask you to move.
I'll be finishing on time, don't worry. This is to show that the AFR device improves the exercise capacity. This shows the 6-minute walk test is improved, and this slide demonstrates that there is improvement in quality of life by the questionnaire from Kansas City Cardiomyopathy Quality of Life questionnaire. So current indications for AFR and left heart failure is NYHA class 3 or ambulatory class 4, EF more than 40%, exercise pulmonary capillary wedge pressure equal or more than 25, and differential between pulmonary capillary wedge pressure and RA of more than 5 millimeters of mercury. So the take-home message is implantation of AFR is safe, and the shunt remains patent on medium-term follow-up up to 3 years. Patients with both preserved ejection fraction and mildly reduced ejection fraction show surrogates of heart failure to improve following AFR implantation. Atrial fenestration in diastolic function of either ventricle is effective in improving symptoms, and AFR in patients with pulmonary artery hypertension improves survival and quality of life. Thank you for listening.
Thank you, Joseph. Excellent talk. Thank you very much. Okay, so if I can just ask a couple of sort of practical questions, really. What do you do with these devices and anticoagulation stroke antiplatelet regimen for them from a practical point of view? Are they all anticoagulated?
When I receive, all of them are on some form of anticoagulation. So I do not, if they are not on antiplatelet, I add an antiplatelet drug. Otherwise, I follow up what the anticoagulation was followed for the patient.
Yeah, and it seems, you know, a really exciting device and an exciting technique, but numbers remain quite small across the world. Why do you think that is, Joseph? Why do you think this hasn't had more traction to this point?
I think it may be because lack of acceptability. Even in my institution, it was real problem to get acceptance. But now I have patients, you know, increasing number of patients. So, and also I get referred most of the patients that have AFR put in, and you can see there is a significant increase in the numbers in the recent, say, past 6 to 9 months. The other reason is perhaps that I think Occlutech has taken more seriously now with clinical trials, because unless we have good data to support this, most of the data is from compassionate use or from individual providers. So unless we have a systematic data set to show with control trials, it is difficult to convince scientific community in general the validity of this procedure and the device.
And do you have any, have you had any technical issues with implanting the device? Any tricks or tips or any issues that you think getting this device into the septum in this sort of patient?
I think the first patient was my most difficult patient. That patient had an ASD device, an oversized atrial septal device put at the first instance about 10 years back. So again, I am a believer in 3D echo. So the only place I could put an AFR device was just at the insertion of the IVC. There was a triangular portion where I put the device. So I believe in 3D echocardiographic assessment of the septum and to see where is the thinnest area, and you can guide the operator. Second thing is the right atrium is so huge in pulmonary artery hypertension. Sometimes there is only a few millimeters separating the RA part of the septum to the LA. So again, I use extreme caution in such situations, and sometimes I look to the superior border, because here it doesn't matter where you have the atrial fenestration. So quite often I go, it is a convex surface that you have, or concave from the right atrial side. So I go towards the SVC border, where the secondum septum is much more thinned out, and there is more separation from the left atrial wall. So these are the two things that I have come across.
There's a question from the audience that's come through text, and the question is, can you do an AFR with local anesthetic and no TOE? Well,
I tried it once and it didn't work very well, because this was a patient with quite severe pulmonary hypertension. She was on the lung transplant waiting list. And I took to the patient, and she did not want any sedation. And I gave local, and halfway through, I'm about to puncture, and then she says she wants to pass urine. You can't put a, and it just, every time I'm about to puncture, she just would come up with some problem. So I decided after that I wouldn't give. I can do it under sedation with transthoracic, but patient cooperation is very important. And sometimes if they want to be awake, it is much more difficult.
Yeah. Anyone, any other questions out there? Anyone from the faculty or?
John, there's another question. Sorry, I interrupt, from Girish Savnis, who's an old friend. How do you size the AFR device for individual patients, and what's the minimum oxygen saturation at which to implant the device in pulmonary hypertension cases?
I think you might have missed the chart where I showed the different atrial pressure differences and saturations to recommend what is appropriate size. In general, most of the patients, about 80% of the patients, an 8 millimeter device is fine. I usually use a 5 millimeter thickness, but it depends quite a lot. Suppose the saturation is in the low 90s or high 80s. Say the lowest I had used was 89%, and you can get up to 93% with a bit of oxygen. Not because I would never do a procedure in oxygen, because that's the only thing to improve the saturation afterwards. But a trivial amount of oxygen, if you show that you can improve, then I go ahead with atrial fenestration. But depends on the atrial pressure between left and right atrial pressure, as well as baseline oxygen saturation. But if with minimal oxygen, if you can't get into the low 90s, I will never attempt a atrial fenestration in that patient.
Great.
Iqbal, any other questions?
No, I think the question was really about the safety in these pulmonary hypertension patients of even having the anaesthetic. So clearly, Joe, you've got an experience where although they're fragile, they're not that fragile. They can have a general anaesthetic for this procedure with the proper TOE 3D guidance. So that was the question I had, and it seems that you've answered it. They are safe to do it that way.
Yeah, my main problem is from the referring physician. They instruct, because they say this patient should not by any reason get anesthesia. And that's where the problem is, because they are scared of induction and acute decompensation. But a good cardiac anesthesiologist, I never had a problem with induction.
Well, I think that's really, really interesting, Joseph, and we should thank you for getting up so early on across the pond. I know it's, what time is it now for you? 5:30, something like that?
No, it is better. It is about 6 o'clock.
Okay, well, thank you very much for your talk, and we should move on.
Thank you.
Mark, Mark, are you there?
Yeah, I'm here. Should I?
Yeah.
So I think Matt Jones is next, who's going to hopefully show us something very interesting about using the regulator for other indications. So Matt, thank you very much. Go ahead.
Thank you very much. Can you see the slides?
Yes, we can see them.
Fantastic. So good afternoon, everyone. So for those that you don't know me, my name is Matthew Jones. I'm one of the consultant pediatric and adult congenital cardiac interventionalists at the Evelina and St Thomas's in London. I'd like to thank you all for the chance to speak today, and for rather free-for-all title of using the atrial flow regulator for other indications. And I'm pleased that Joseph spoke about heart failure and PAH, because I deliberately left that out of today's talk. So we've talked about the Occlutech flow regulator already. As Joseph has said, it's a relatively new device as far as transcatheter devices go. It's a circular donut-shaped device with a pre-specified hole in the middle, designed for placing in the atrial septum, but in theory allows reliable mixing of blood between any two chambers that you could place it between. I won't dwell on this in too much detail at the moment. It's marked for heart failure and used as an investigational device for pulmonary hypertension, but it also has some theoretical other uses. So, of course, with that being the case, the literature is slowly building on it, where else people might want to use this novel device. Unfortunately, for the purposes of this talk, it's currently all case reports without any large series. I know that Joseph himself is working on a series of this at the moment. And interventional cardiologists around the world have been using the Occlutech AFR device to improve atrial mixing, to improve quality of life and palliations for unrepaired congenital heart disease. They've used it to create Fontane's fenestrations in a Fontane circulation as a treatment for Fontane failure, and also conversely to reduce the size of a Fontane fenestration in a child with marked saturation. Alan Fraser's team at the Brompton have expanded the potential for heart failure uses using the atrial flow regulator device to create a left atrial vent in a patient on a child on VA ECMO. And there are even some animal experiments of creating a pot shunt between the descending aorta and the pulmonary artery using the AFR device. So what I thought I'd like to do today is just tell you what our contribution to the cause is and how we've put our case into the literature as well, which is transcatheter creation of a pulmonary artery to left atrial fenestration in a failing Fontane circulation. So this again is, of course, another case report. It's been written by one of our fellows, Emma Pascal, and has been accepted for publication. And it's very similar to one of the previously adult demonstrated cases where where Nick Haas's group had used the Occlutech AFR to create a fenestration. I'm acutely aware today that not everybody dialed in is a pediatric or congenital cardiologist. So here is a crash course in congenital cardiology. And the Fontane circulation, as you can see in the diagram here, is the final result of a series of operations to treat babies who were born with effectively single ventricle circulations. The result of this series of operations is that the systemic venous return from the IVC in the superior vena cava is directed straight into the pulmonary circulation without passing through the heart, and the single ventricle is used to pump pulmonary venous return to the systemic circulation. So, of course, this inevitably results in chronic elevation of systemic venous pressures because there's no pump in the return venous circuit. And over time, this leads to hepatic dysfunction and gut dysfunction in the form of protein losing enteropathies, causing low albumins and edema. And in an attempt to avoid this, the surgeons will often create a small fenestration between the systemic venous circulation and the atrium in order to allow this pressure to be released and augment the systemic cardiac output at the expense of what is hopefully a mild desaturation only. However, spontaneous closure of this small fenestration is surprisingly common. So our case was that of an 8-year-old child weighing 19 kilograms. They were born with a double inlet left ventricle and discordant VA connections and a ventricular septal defect. They were palliated with a series of operations outlined in the slide and ultimately ended up with a Fontane circulation with a lateral tunnel and a 4 millimeter fenestration between the systemic venous return and the pulmonary venous atrium. He did relatively well after his series of operations and followed our usual surveillance pathways for a few years. But at the age of 8, he developed and progressed into fulminant protein losing enteropathy because of gut dysfunction, evidenced by worsening edema and a very low albumin and a high stool alpha-anti-1 trypsin. Despite the medical therapies along accepted, but perhaps not proven lines with diuretics, pulmonary vasodilators, I've gone too quickly. Where we go in? Pulmonary vasodilators, steroids, and albumin infusions. He got worse and ultimately ended up on the pediatric intensive care unit on inotropic support. The imaging assessments had demonstrated a proximal left pulmonary artery narrowing and suggested that this surgically created fenestration has closed. As ever with all patients with congenital heart disease, they went through the regional MDM, and we decided to proceed to a transcatheter intervention on the left pulmonary artery and attempt to recanalize the fenestration. We started by stenting the stenotic left pulmonary artery. This is relatively straightforward and not really the focus of the talk, so I'll show you the before picture on the left and the after picture on the right, where there's a Vallejo stent in the left pulmonary artery, which you can see from the IVC angiogram. You can see on the angiogram here on the left after stenting that the surgically created fenestration marked by the surgical clips is occluded, so we're not able to recanalize this, so we opened up a new communication with a Brockenberg needle to puncture from the baffle into the systemic venous circulation. And that all went very well with a stent placed And you can see with the IVC injection, there's flow into the common atrium. Correspondingly, as Joseph has said, with the pulmonary hypertensive patients, the SATs fell from 95 to 85. He did relatively well on the first day, and the early post-procedure course was uneventful. But after 24 hours, his SATs jumped up again, and the echo showed that there was no flow through the atrial septal stent. We gave a couple of days of thrombolysis without any effect and went back to the MDT. The answer was really easy. They said, just create another fenestration. What can the problem be? So the next question to us was how. And at the time, there was a single case report of using the Occlutech AFR from Nick Haas's group by creating a Fontan fenestration directly from the base of the PA into the atrial mass. As ever at the Evelina, we weren't short of wanting to try new things. So we called Occlutech and said, oh, where have we gone? So we called Occlutech and said, well, I've lost a slide there. So we called Occlutech and said, well, can we have an AFR? And their response was, what size? And we didn't really know, and we didn't have all of Joseph's excellent data looking at how the pressures and the mixing changes. We said, what size can we have tomorrow? And we got a 10mm device with a medium height, so the 5mm height. You can see from the IVC angiogram here that the stent marked by these yellow markers was occluded with no flow into the atrium and no flow across the baffle. So we accessed the floor of the pulmonary artery from the right internal jugular vein and used a BRK needle and a 7 French Mullin sheath to puncture the floor of the pulmonary artery into the atrium under fluoroscopic and transesophageal guidance. As one of my predecessors was rather fond of saying, the next step was to get a rock star wire position. So we managed to pass a soft wire from the internal jugular vein to the pulmonary artery, through the left atrium, to the left ventricle and out of the aortic valve and to the descending aorta, which we then exchanged for a stiff wire and updilated this communication with high pressure balloons. We then passed the 16 French introducer sheath. We often go one size higher than manufacturers recommended just to give ourselves a bit of wiggle room. And as you can see on the left here, we deployed one retention disc in the atrium using fluoroscopic echocardiographic and angiographic guidance for the positioning. We then followed this with the, as you said, the 10mm medium height Occlutech AFR device with a second disc on the pulmonary artery side of the atrial communication. At this point, even we were surprised how well this seemed to have gone, so we let it go. And as you can see from the final angiogram in the inferior cava, which is the middle slide here, you've got lots of flow from the IVC injection directly into the atrial mass, so reducing the pressures. We now had a lovely big communication between the systemic venous circulation, and correspondingly, the saturations fell from 95 to 75%. The child did very well after the procedure. There was a period of transient complete AV block, which was resolved over a day or so, probably from the stiff wires curve that you could see looped at the base of the atrium, probably quite near the AV node. His ascites and edema improved over 2 weeks, such that he lost 4 kilograms in weight, and his albumin came up from 22 to 24. He spent another month in hospital because he was a very complex patient.
Move to the end. You're well into the last minute.
We're there. And went home a month later. He's had a 12-month follow-up and he's doing very well. So this was the first use of an AFR device to create a fenestration within the pediatric group, and adds really to the literature on using the Occlutech for other indications.
Great, thank you, Matt. That's a really, really nice case. Thank you for sharing that with us. So, are there any questions? Anything from the floor?
No, there's nothing from the audience, but if I could sort of summarize then, say that it's a very interesting technology, and I think it is easier to use than some of the ones that were out there already. The question, the question I have then is really the bigger population for the adult doctor is the heart failure population, because I mean I work in a pulmonary hypertension center, and they've in the last 18 months found one patient they thought might be suitable, who then promptly said, no, I don't want it, even though I'm syncopal. So the heart failure population is the one where we're sort of really looking at. And have any of you managed to engage your heart failure team? Because I think it's you guys like Joseph and the team at Evelina that would be accessed. So have you made any approaches to the heart failure teams?
Joseph, that's probably for you.
I had, sorry, I had no success so far from my own institution, but I had 2 in Mayo Clinic, 1 in University College, UCLA, University of Los Angeles. And it's interesting, those patients were younger. One in Mayo Clinic was 32-year-old and the other one was 16-year-old, both with diastolic heart failure of the left ventricle. And the one from Mayo had very interesting physiology. Resting LVDP was 12. And with exercise, the LA pressure would shoot up to anywhere to 30. And the diagnosis was, I have never seen it across, but this was supposed to be a restrictive left atrium. And she's significant. I mean, they initially did a balloon dilatation of the atrial septum. And when it became restrictive, they put a AFR device. And I was personally there for that procedure. And significantly, that patient improved following that. And excellent result at the UCLA as well. So it is getting more, I think it is people who are using this device is already familiar with other devices, and they are very taken up by the ease of, placement and if necessary, you can, retrieve it. And that's what they are really appreciative of the device.
I think that without, obviously this is an Ocular Tech sponsored conference, but I think it is worth saying that we need this sort of device. I mean, clearly this device is now finding all sorts of potential avenues, and without companies that are prepared to invest and help us with these relatively bespoke and small volume procedures, there's limited potential to move on. So I think we should, we do need to offer our thanks for that, really, I think.
I've got a quick question for Joseph. Joseph, if you put in the larger 10mm hole device, can you then downsize it to the smaller one?
Yes, you can put an 8mm into a 10mm and nicely sits in. So that's another important use of it. It is versatile. You can improve the fenestration.
And that would be music to Occlutech's ears. 2 devices.
Yeah. But there will be patients where you can't get the numbers just right, and it's easier to, if it's easier to downsize rather than upsize, then it supports the use of the bigger hole.
You can try, because sometimes what happens in my first patient, the ASP device, which was already there, was impinging on the waist. So I could balloon dilate the device to get a bigger dimension. So you could potentially do that, but it is much more easier to downsize.
Downsize, yeah. There is a question, Iqbal, I think, from Rob Butler. I've seen it. Yeah. LVEDP at rest or exercise, or wedge V-wave at rest or exercise for diastolic dysfunction, and the use of AFR in that scenario.
I mean, the AFR is usually recommended regardless of the LVDP if the pulmonary capillary wedge pressures is on exercise is more than 25, and there is a 5mm gradient between RA and LA of wedge pressure. I think you can get a good symptomatic relief in those patients.
I just asked Joseph a question, Jack. Joseph, you said when you downsize, or if you were to downsize one of the defect sizes, so you go from a 10 to an 8, do you need to change the height of the device? Do you need to put a longer one in?
Absolutely. I mean, I have done it on bench, not in a patient, but that would be the recommendation, because otherwise it may get pinched inside. So it is better to have a slightly longer. If you put a 2, we can put a 5 waist in the second, so that that will be more appropriate.
Matt, can I just ask you a question, please, on your case? One of the problems with refenestrating these sort of patients, most of ours are extracardiac Fontans, and the tube is extremely tough. Do you see that there might ever be issues with a flow regulator of this size, creating a hole big enough to accommodate the device?
I mean, this is a very compliant device, as you know, on the waist of it, so it's pretty soft. Certainly, when I'd done a couple of these cases in the PH group when I was at Great Ormond Street with Sachin and Graham went over, and there was certainly one that the defect was probably a little bit smaller, or smaller than they'd anticipate, where they placed a stent inside the inside the ring just to hold it open. So I think you definitely have to pre-dilate these to make them make it a bigger hole than you would normally do if you were just putting a stent in, because they're self-expanding to all intents and purposes. And then you have to have the option of placing a stent inside it to support that, I think.
Yeah. Okay. Thank you. I think that's a really interesting conversation, really interesting discussion. It wraps up that little section on AFR. So we'll move on. Our next speaker really needs no introduction. Bushra Rana, who's the Hammersmith group, and Bushra is going to talk about echo assessment of paravalvular leak. Bushra, floor's yours. We can't hear you, Bushra.
Okay, can you hear me now?
Yeah, we can hear you now.
Hopefully you can see my slides.
We can see your slide.
Wonderful, lovely. So I wanted to thank the directors for inviting me, and of course the organisers in the background who nobody really hears about, but I have to say this conference has been running very well, and as ever very impressed and very grateful for their kind of kindness and support of all of us, and of course Occlutech for supporting this meeting. So as I say that, see if I can move my slides. Yes, I can. Okay, so I've got 10 minutes. So I'm going to just say from the outset, I've got a lot of information on my slides. These sessions are being recorded, so you'll be able to see all the detail, but I feel like I can't just give you headlines without actually describing what I'm trying to tell you. And what I'll do is I'm going to go through highlights, as you can see here, but as I go through them, there'll be more information on the slide. So at your leisure, you can look back and read through the detail so you get a kind of the meat of what I'm trying to say. So in terms of paravalvular leak, what's important to understand, and we've already highlighted this and alluded to this through the talks, is that these patients are not straightforward. And it's important to understand what's actually going on and what actually causes a paravalvular leak. And it's all about this distorted native annulus and the fact that the tissue is friable. And the two big groups of patients that we deal with are those that have had either some kind of infective insults or endocarditis, or those that have severe annular calcification. And in these patients, typically these are the ones that have may have long-term steroid use, so you can think about the comorbidities that come with that. They often have renal failure, and they may have had things like radiotherapy in the past and cancer treatments. And of course, they have all the other cardiovascular comorbidities. And so these patients are frail, and redo surgery in the setting of paravalvular leak carries often significant risk. But even those that have redo surgery for the paravalvular leak, what is important to note is there's often a high incidence of residual leaks. Okay, so when it comes to diagnosis, again, taking a step back, there's some key things to remember. The first is remember that transthoracic imaging, because of the acoustic shadowing, will limit the assessment of paravalvular leak. So you can see transthoracic picture here on the left, and on the right, you can see that a leak that looked very small, but in fact, the keen eye will already notice this very turbulent jet at the back of the left atrium is in fact a severe paravalvular leak. So the one exception to that is, given the two valves that we typically look at, aortic and mitral, will be the aortic valve prosthesis, and they are anterior leaks. So they can often be well seen transthoracically, but of course, TOE is the gold standard in terms of documenting everything. Now remember, I've already said these patients are complex cardiac cases. So be sure that the cause of their symptoms is not something else that is significantly contributing, not just their paravalvular leak. So remember that arrhythmias, particularly ventricular ectopic, so a high burden, or atrial arrhythmias, may be the result of their breathlessness and symptoms. These patients may have pacemakers, and or they may have bundle branch block, so they may have LV dyssynchrony, which may need correction through CRT. And then of course, medical optimization of heart failure, etc. In terms of assessment, remember that serial data is key because they often have abnormal hearts. And so monitoring and looking at serial changes in chamber size, LV, LA, right heart, pulmonary artery pressures, and the progression is very important. And then lastly, I just wanted to remind everyone that in patients who might have modest severity of paravalvular leak, it may still be clinically relevant. And that's typically, you see that in patients who have a stiff LV. So these are often the aortic stenotic patients who have then had a valve replacement. And then they end up having a degree of regurgitation that may not be severe, but may be enough to be causing problems because they've already got stiff ventricles with high LV EDPs, and they become quite symptomatic. So they too may need treatment as well. So So the last thing about diagnosis I just wanted to highlight was that in terms of assessment of the valve, so there's more information here, as you can see, but the two key things, one is don't forget that while gradients and velocities are important, you have to put it into the context of the patient. So doing valve area measurements and the stroke volume index in terms of their flow state is very important. And the other key thing is remember that and analyzing the anatomy of the valve, irrespective of what the gradients are telling you, is very important because you can be fooled. So remember that 3D imaging and assessment is very important. So when it comes to quantifying the leak, so the key message here is it's about understanding that both in terms of severity assessment and also the sizing for the defect, it all rests on understanding the anatomy of this defect. And while 2D imaging and 3D imaging are great, because of all the debris and the calcification of the abnormality of the tissue around the sewing ring that creates the paravalvular leak, directly looking at the hole is not enough. And so to help us understand this morphology in detail, what we really need to do is use our color imaging, and it can be 2D and 3D. And when I say 3D, I mean the formats of X-plane as well as or simultaneous multi-plane imaging, or direct 3D color using your live 3D imaging as well. But the key is to understand the jet morphology, because as the regurgitation occurs, you get three components of the jet, and understanding that concept will help you find and locate exactly where your jet is by using the methods I've demonstrated on this slide. And what you're trying to do is find the flow convergence, find the vena contracta, the narrowest portion of the jet as it goes through the defect, and then the expansion of the jet. So if you can find all three components, as you can see here, you can then find the narrowest portion, and you can then look at it in detail. You can work out, is this a discrete lesion? Is this in fact a sieve-like defect? Do I need to think differently in terms of sizing? Or indeed, is it a serpiginous tract that we're going through? And if you understand this concept, you won't get it wrong. And then in terms of sizing, so this is both in terms of severity assessment and the sizing for the device, because they're both the same thing. It's all about finding the vena contracta and then assessing it. And what you can see here is, and I'm going to speed up this video for size, you can see here in the top image here on the left, you've got the short axis view of the defect. So we're right on the defect there. And what I'm trying to do in the blue window at the bottom and on the right top, the red window, is find the defect and angle so that we're cutting through the three components of the jet. And then when I find the narrowest portion as it goes along the sewing ring on the outside of it, as you can see here and here, what I'm then doing is able to see it in short axis, and I can measure the long axis and the short axis of the defect. And so I've accurately defined its size, I've actually accurately defined its shape, and I can then see how it transverses. Is it a big hole all the way through the sewing ring, or does it narrow, or is it sieve-like? Okay, so that's a take-home message, and the measurements here, for example, at the bottom. So if the defect is 12 by 5, then that's the size of the device we're looking to use, and you'll hear more about that as the talks go on. So in terms of the imaging, the key is for transesophageal echo, so that's the gold standard, it's all about landmarks and a systematic approach. So again, there's a lot on this slide, but on the left, I've highlighted the key landmarks for your mitral valve paravalvular leak assessment. And there are three key landmarks: atrial septum, your LA appendage, and your aortic valve. You can use a clock face, and I know that Iqbal does like a clock face. I like to talk about it in terms of anatomy and where everything is orientated according to key landmarks, because in terms of imaging, it then fits in with when I'm either in theatres or in the cath lab or in the echo lab, and then the whole thing is the same and unified, and then we all know what we're talking about. So I prefer to use landmarks myself, but of course you can use the clock face too, because I know many operators like that. So one is know your landmarks, and then know the imaging planes, and I've set out the TOE protocol here, and the key things really to highlight here is most of the imaging can be done to the transesophageal views. It is important to know your deep transgastric views too, and I will come back to that in a moment. But in terms of the procedure guidance itself for mitral, remember that the working view that I find often best is the 4 chambers, 0 degrees, because I'm usually using my 3D formats to do that, as you can see here. If you do an antegrade approach, then a transeptal puncture is also key in terms of guiding the position. And typically, if you're looking to do that, we're looking posterior puncture, typically mid to high on the septum if we can possibly do that. But of course, sometimes anatomically, that isn't so straightforward. And then in terms of the aortic valve, paravalvular leaks, again, landmarks are key, as I've demonstrated on the left of the side. And on the right, I just wanted to highlight with the protocol, particularly important to be good at your deep transgastric views, because you often don't see the valve mechanism well in your esophageal views because of all the shadowing and splay across the valve. So that's really important to remember to do that. And in terms of the procedure itself, the guidance, I typically am going between 50 degrees and 135-degree view to be able to demonstrate the short axis of the valve, guidance of the sheaths, and also transversing through the defect itself and into the left ventricle. And then when it comes to the device deployment and positioning, remember that what we're trying to do is get the views that allow us to see the whole sheath in its entirety, the device being opened, being pulled back to the level of the valve, and then of course being deployed. And I've again given some key thoughts there as to what we're looking for. And then lastly, just to end, in terms of follow-up, it's the same principle really in terms of the clinical assessment. And of course, I must add that doing hemolysis screens before and afterwards are key. The transthoracic protocol is important, and I've given one here for the, just because of time, just the aortic valve side, but of course that's very important, a systematic approach. But remember that you can miss leaks, so you need to go off axis and think outside the box. And really, having gone through all of that, I just wanted to summarize by saying that really transthoracic imaging has some limitations. TOE really is the gold standard in terms of imaging, and really our preferred method for paravalvular leak closure is indeed percutaneous rather than going for surgery. And I'll stop there. Thank you.
Bushra, thank you very much. That's just spectacular images as always. So thank you you must have taken a huge amount of time putting that presentation together. I think we do have a little bit of time. I mean, your talk, mine follows very much on from yours. If anyone has any questions at this point,
there's a question from the audience, and that is about there is a review occurring in the UK, as I'm sure we all know, about paravalvular leak closure, which reads in my mind as total nonsense. But one of the deficiencies there is they say there isn't a randomized controlled trial of surgery versus percutaneous closure, which puts to mind that there isn't a randomized control of wearing a parachute and jumping out of an aeroplane either. But that's my view. Bushra, what's your view?
So I guess I can say anecdotally, really, because early on when we started looking at these, we did send some of these patients for paravalvular leak closure surgically, and I was so disappointed when 3 patients, I can tell you, came back with not just leaks but worse leaks at the end of it. And that's because of the nature of the annulus. The reason why you've got the leak in the first place is you have a horrible looking annulus. It's very diseased, and there's not a lot of surgery can do to correct that. And really, we just have to accept it. And the way forward is to put a device in there and not to try and rehash the annulus, because you'll only make it worse, in my opinion. So that's my anecdotal advice.
It'll be easy to put this through, wouldn't it? Because the cases are the ones where surgeons, as Bushra has just said, have had difficulty because of calcium and whatever, and they can't really get good sutures there. And so it's the surgeons who are then pushing for a catheter approach.
Yeah.
So how are you going to randomize?
The only exception to that is when the valve is unstable. You know, when there's a dehiscence that is sufficiently large that essentially you have a valve that isn't stable, and that's usually, you know, more than 40% of the valve ring, and in that situation, sure, you can put devices in, but it generally doesn't fix the problem.
Yeah, but that's different. I mean, if the valve is rocking, the prosthesis is rocking, then that has to be surgical, because you're not going to be able
Can I bring Phil in? Because Phil
I
is
just wanted
connected to the big boys in cardiology. What is the thinking behind this review?
So we, as you say, Iqbal, NICE are appraising this as at the moment. It's out for consultation, and BCS and BSIS are making representations. But in my role on the heart editorial team, I was quite surprised at how cynical the general cardiology community is with percutaneous paravalvular leak closure. We're all enthusiasts and we think it's a no-brainer, but you'd be very surprised if you speak to non-enthusiasts. There's a lot of cynicism about this, and I think it's because of lack of understanding. They don't really realize quite how simple it is, quite often quite what good results we've got. And I think maybe it's up to us to start to get some trials together and get some data out there to let people know in the broader cardiology community how effective paravalvular leak closure can be in what is a very unattractive surgical patient population. Exactly as Shaq says, how can you do a randomized trial? It's impossible because we get the surgical turndowns. But I think it is incumbent on all of us to try and get the registries and the data out there, because non-interventional cardiology community, very, very cynical. We'll see what NICE say, but we've asked Paddy Calvert to do a review for heart to sort of update us on all the latest data, but there is a lot of cynicism.
I have a technical question. Oh, go on, Bushra.
Sorry, Phil, but just to emphasize that point. So it's not even the paravalvular leak and the issue around that. It's actually as you just highlighted, it's the comorbidities and the fact that the patient's population is actually a high risk population, and the surgeons won't even look at the paravalvular leak. They'll just say, I'm not touching that patient.
Well, because of what Shaq said, because it was a hard operation the first time round. Yeah. That's why they've got a paravalvular leak usually. Yeah. Yeah, I mean.
Yeah. The other thing, Phil, to bear in mind with all of this is it's really obvious that actually we need better care for patients with surgical valves. You know, I think what interests me is that there are so many paravalvular leaks out there that aren't detected or are just brushed off as being meaningless. And I think there's extreme, patients get valves and they get discharged back to very, very nebulous follow-up protocols and strategies, which are almost designed to miss important problems. So I think there is a serious issue with how this whole patient cohort is looked after in general cardiology.
Absolutely.
John, I've got a quick technical question, if I may, for Bushra, and that is, Bushra, when it comes to dealing with mitral paravalvular leaks, if it's a big leak and we're putting a rectangular device, whichever PLD or whichever, let's say I'm delivering it as Iqbal would recommend from transseptal approach, I need to get the device, the rectangular device, on axis parallel to the leak. On transesophageal echo, how well can you show that from the left ventricular side?
So the issue is, if you're imaging from the esophageal windows, the acoustic shadowing of that valve is into the LV. So if you're trying to position your LV disc correctly, then you're struggling. And you can go off axis, you can try and cast the shadowing off, but it's not always easy or in fact possible. So that's where I've emphasized that the deep transgastric views or the transgastric views are really important. And I would say that these patients are GA, and often in the echo lab, most people don't sedate their patients particularly well. It's often a smash and grab sometimes from what I see. I'm a big believer in fentanyl and midazolam, but what it does do is that you need time. You should be spending time getting into the stomach and having a good look in all the views and making sure you can access, this applies to the aortic as well as the mitral, but you can see the LV cavity well and you can see your positioning well. And so I've now used more and more some of the deep transgastric views and using X-plane to find the device and to bring it in, and then switching to 3D, because often then the shadowing is now cast in the opposite direction onto the left atrium and you can see what's happening on the LV side. So that's what I would advise.
Okay, from transapical, we don't have that problem.
I mean, we're being given instructions that we need to move on. I think Mark Turner is.
I'm here actually, John.
Okay, fine.
So sorry, I'm trying to do a case.
I think we'll forgive you because you're obviously going to retrieve a device. So I'll introduce myself. You concentrate on getting.
He looks as if he's in a wheelchair.
Okay. So we haven't started yet, John. So, but that's fine. I'm sure you can ably introduce yourself.
Yeah. Well, I'm going to I'm going to share my screen now, and it's here we are. It should be up and running. It's not easy following a talk of like Bushra's, which is so beautiful and well put together, and this is very much the agricultural side of paravalvular leak closure. And I'm also very aware that I've only got 10 minutes, so I have pared this down to the basics, which frankly haven't really changed a great deal over recent years. So this is Paddy's paper he first authored. We've just mentioned him a second ago, and this is data published in 2016, but it relates to older paravalvular leak closures in the decade prior to that. And I'm not going to go through this paper in detail, other than to say that this is one of the outcome graphs. It's MACE rather than survival, but the two look very, very similar. And I put this up to show that if you're going to do this procedure, you've got to do it well, because patient outcomes are really dependent on you getting these defects closed. So if you come out of the procedure with a moderate or severe leak, then these patients really don't do very well. So it's incumbent upon us to do well and get good closure rates for these patients. Otherwise, we're doing them a major disservice. And in that regard, what do we have in our armamentarium to deal with paravalvular leak closure? The paper actually had a bunch of devices. I think there were probably 6 or 7 different occluders used in that era for closing paravalvular leak. But I would be surprised if anyone who was doing this procedure seriously now was using anything other than the 2 main occluders, the AGA device, the formerly known AVP3, which has metamorphosized into a true paravalvular leak device now, as it's had its name recognized for that. That device is a very good device. It has a central core that's between the biggest device is 5x14. Its big advantage is that it's relatively flexible and it fits through a small sheath. So you can get all of these through a 7 French delivery sheath, which can be useful for difficult holes. And then the Oculatech device, the paravalvular leak device, is a much more varied occluder. It has different shapes. It's either square or rectangular. It has 2 different cores, so a twist or an occlusive central core in the manner of the AVP3. And it's much, much bigger. So it goes up to 14 by 22. So it really is a very, very large device in its bigger sizes. It has the standard ball bearing delivery system, so there's a degree of articulation. And if there's a downside to this device, it's that it does require a larger sheath, and the big devices do require quite big sheaths. And I knew Bushra would do a really, really good job with the imaging, so I'm not going to say a great deal about this, other than it's absolutely key for this procedure. I can't think of anything else that I do in the lab where the echo guidance is more important. You need a good team, you need good understanding, you need consistency. And if you're going to do this, you've got to have a very skilled echocardiographer working with you. I'm lucky I have a couple who are excellent, and we speak the same language, and they provide me with superb imaging. Echo Nav, which is a Philips proprietary system on their X-ray equipment, on the fluoro equipment, is very, very useful. It allows you to mark the holes on echo on fluoro, and I found that really helpful. And I'm going to put no other imaging up other than this, which is really saying what Bushra said, which is you do need to speak the same language, whatever it is. You've got to have some consistency. It's really nice to have a biplane lab so you can line the valve up perpendicularly. It gives you a degree of extra information. And the final thing I've put on here, just to remind myself, is that CT, I think, is increasingly potentially useful for these patients. I think that with the superlative CT images that we can get these days, combined with some of the new software packages, I think that CT has a role in understanding some of these defects before we go to the lab. Neil mentioned about reducing contrast dose, X-ray dose, and I think that, you know, we do have good imaging, and I think that CT should be deployed in some of these patients to shorten the procedure and help as much as you can. So the procedure itself, aortic's actually a relatively straightforward procedure, generally performed retrograde from the femoral artery. You can go radial if you like. It's essentially crossing with a wire, usually a Terumo, then using your stiff support wire of choice. For me, a super stiff, other people I know use a Safari, and then using a peripheral intervention sheath, shuttle sheath, destination, flexor, something like that, to then deliver a plug. And these are generally relatively easy, but the truth is that they are relatively infrequent in my practice. I probably only see one for every 6 or 7 of the mitrals. This is a straightforward metallic AVR with crossing with a Terumo wire, and then delivering a 6.3 PVL device via a 7 shuttle, actually relatively straightforward with a good result. Increasingly, we do see some leaks in the TAVI population. So this is a patient of my colleague, Chris Malkin, an elderly gentleman in his 90s, severe symptoms after TAVI, a really severe leak. The issues here are not to get caught within the frame as you're trying to cross. And secondly, of course, the left coronary is in play here, so you have to be sure that you're away from that. But in fact, it's a relatively easy job to occlude these, and in this case, we delivered an 8.4 PVL device via a 5 flexor sheath, and it sat really very nicely around the edge of the frame, avoiding the left coronary with a really good final result, and perhaps more importantly, a dramatic improvement in this patient's symptoms. Mitral is much more involved and much more difficult, as we all know. The most commonly used approach is antegrade via the right femoral vein, puncturing low for defects that are close to the septum and higher for those that are more lateral. Steerable sheaths are essential, so the Agilis or the Oscar Destino sheath is one that I've become quite fond of. Because it's big, it goes up to 12 French, and particularly for the Ocular-Tech device, that's useful. And then very often you're faced with using telescoping techniques, using wires, catheters and sheaths through each other to get into the ventricle and deliver a device. And I have to say that I find this a pretty reliable technique actually with modern equipment. If you're lucky and there's no AVR, you can rail out of the aortic valve, snare and form a loop, which gives you a degree of traction if necessary. And sometimes, particularly for the septal defects, that can be useful. We kind of mentioned other approaches, transapical. We've talked about that in the discussions. There's always the option of going retrograde via the aortic valve. If there's no mechanical AVR, and I guess I won't say any more than that, other than they are approaches, and we've kind of debated those as alternatives already. So this is I'm afraid my clips don't seem to be repeating, so I'll just have to repeat them myself. This is a fairly standard case. A metallic MVR with a significant paravalve leak in the anterior position. This was actually a gentleman who was stuck on ICU after a surgical AVR, MVR, with the surgeons claiming that the issue was his lungs, when in fact he turned out to have a V wave of 35. A considerable leak. I relied completely on my echo colleagues and friends to give me dimensions here. We work on the circumference of the valve and come up with an idea of the size, and it's pretty consistent. And in this case, then we did a transeptal puncture. I used an Oscar sheath, the Destino sheath, crossed with a JR, and then delivered an Ocular-Tech device, quite a large one, a 16.9 device. Rectangular shape via a 10 French flexor with, in this case, complete abolition of the shunt, and the patient did very well, extubated, went home and did well in the longer term. So I'd love to show you more, but I am actually determined to stay within my 10 minutes. I'll conclude by saying that this is an important procedure. It's interesting, the debate we've just had with Phil about the degree of cynicism. I struggle with that because what I see is a very symptomatic patient group who gain hugely from this procedure, assuming they don't get hemolysis. Aortic is much easier than mitral. I think it's very reliable when you don't have a rocking or unstable valve. I think that we have most of our bases covered now with modern devices and sheaths. And I'd finally just want to reiterate what I said at the beginning, which is that bad procedures equal bad patient outcomes, particularly in this particular lesion. So it is beholden on us to do a good job for these patients. And I really do think that volume and expertise are important and remain an issue because this is a relatively rare procedure. Thank you.
Okay, John, thank you very much. I don't know if Mark is still tied up, but I'll step in. So Iqbal, any questions?
Yeah. So one is about hemolysis. So I think hemolysis is a reason to close the hole, but I always warn the patients that hemolysis might be the end result of closing the hole. If you leave a pinhole behind, then that can actually create hemolysis. I've had one unfortunate lady, thankfully only one, who had such extreme hemolysis, she got renal failure. A hemolysis took 6 months to settle. And that was with an ASD device I put into a perforated mitral valve leaflet. So I don't think I'll be putting ASD devices into them again. I don't think it's the right device. Bushra told me not to, but I didn't listen to her. Any experience, John? How do you avoid hemolysis?
Well, I mean, the truth of the matter is, Iqbal, that you can't always. I mean, sometimes you find those craggy, oblique, rather tortuous defects going through a very calcified and diseased rim. And it's difficult. I mean, the only way you can reliably ensure you don't get hemolysis is by completely closing the hole. And I don't think we can go into any of these procedures and give a cast iron guarantee. But, you know, I agree, it can be a problem. I do think the modern devices, I think the Occlutech device is very good. It's very occlusive. And so I think these have helped. You know, I think hemolysis was more of an issue when we were using VSD devices and so on, but you can't completely remove it as a problem. It's part of this procedure and this disease process.
May I just add something to that? Because I think I completely agree with everything you've said there, John. And just to add, actually, from my experience, that the ones that get hemolysis are specific sort of scenarios where one is mitral. You see more hemolysis in mitral leaks just purely because of the pressure between LV and LA. It's a different situation. The device type makes a difference, and I'm finding that Occlutech is much better and less likely to cause hemolysis, as you've said. But actually what we should avoid doing is oversizing, I think, into these holes, and really try and accurately size and place what fits that defect. So for example, if you've got a sieve-like defect, rather than trying to get in the biggest sheath and trying to put in the biggest device you can, hoping you'll cover as much, and ending up with a distorted anatomy, and that of course the device that's splayed and dumbbell looking, really awkward shape, that's less likely to endothelize and allow flow through it and create that sieve that would create the hemolysis. So my view is to, and I think I've learned this really from Shaq, is that to downsize and go exactly for the size of the defect, for the size of the device, and that way you avoid all these complications. So I think that would be my addition. And then on top of that, as you've mentioned, avoid ASD, VSD type devices, and particularly in areas where you're going to get a high flow. So if it's sticking out into the outflow tract, that's going to cause hemolysis. It's that kind of concept. If you think about those kind of issues, then you're less likely to run into trouble. So I would just add that to the
I think that the group of patients that worries me, and it doesn't mean that I shy away from treating them, I think there is a distinct group of patients who are patients that have had multiple valve replacements, usually quite elderly. Their disease process goes right the way back into the 70s often. And I think that they often have a pan-annular disease. And what I mean by that is that sometimes you find that further leaks open up. There's something, you know, that they're not static, but actually these patients often get a huge symptomatic relief from the procedure. even if you're then having to go back a few years later and deal with another leak. And I think they're a distinct group. They're often very ill and they're often quite nasty patients. So they're a slightly separate group. And I think they're also often patients that hemolyze too.
John, this is fascinating, isn't it? There's lots of areas that we can cover, but we will be overrunning quite a bit. So let's keep moving.
Okay, well, Mark, I assume, is now in the cath lab, so it then leaves me to invite Iqbal back to talk about a pre-recorded case of a paravalve leak at the Hammersmith. Iqbal.
Lovely, thanks very much. This is really a fruity one, and so you'll be unimpressed with my complete closure of the leak, I'm afraid, but I think there are reasons behind it. You'll be very impressed with Bushra's imaging, and to save Bushra talking, I will mute the video once she's finished giving the explanation of the baseline echo, and then we can mute the rest and chat about it. So I think I clicked.
Welcome to the Hammersmith Hospital, and we've got a fascinating case for you. You will have seen the history already, but in brief, a terrible case of infective endocarditis, both on the aortic and mitral valve with a root abscess, and a fantastic save by the surgeons who replaced the aortic valve, the mitral valve, put a patch on the aorta. Initially, he did quite well. A few months later, he presented with flutter and was in heart failure. And at that stage, it was noted that there was a really dramatic jet going from the LV to the LA. Now, you would think that that was a paravalvular leak, but actually I think it's more interesting than that, as we'll see in a second. So let me introduce the team. Neil Ruparelia is with me, myself, Iqbal, Malik, Chris Cook, our fellow, the fantastic cath lab team, Bushra Rana on echo. So we've got amazing echo, and Claire Boyd and our anaesthetist who's keeping the patient very stable. So that is the team, and there's a lot to discuss here.
Obviously, there's a lot of shadowing here. You can see the right heart's quite enlarged. But we're going to focus on the mitral valve to begin with. There's a tissue mitral prosthesis. You can see the leaflets, which seem to be functioning well. You see a lot of regurgitation in the left atrium, but it's not clear exactly where this is originating from. So if it's coming from the valve, it certainly seems to be over the top of the valve here, but if it's coming from the valve, I need to find its origin. So I'm looking for the flow convergence and the vena contractor. So we're going around the degrees. And as we do, you've already seen actually where the jet is coming from and originating from. I'm just rolling the probe just to give you some idea of that. So it looks like there's actually a jet, not from the valve itself, but in fact from a lesion at the sewing ring edge of the valve. So as you know, this patient has had both tissue, AVR, MVR, and also had a root abscess and ended up having pericardial patch as well. And so if I just stop here, just going to orientate you. So you've got the mitral valve prosthesis here. You can see we're doing some contrast injection in the aorta here. You can see the aortic valve prosthesis here. You can see the leaflets moving. I'm just moving the probe around. But what's interesting is if you look at this region here, so from the aortic root, where the left atrium would be above, and then as you follow that line to where you would expect the mitral valve to be continuous, so the aortomitral curtain, you can see that actually there's a lot of irregular tissue. You can see here, in fact, there seems to be a layer of tissue here. And if we follow that up, it looks like there's a blind ending pouch. And then as we follow that edge right down to the aortic side, you can see here there's an irregularity here. So just to understand that better, if I put some color on, so I hope you can clearly see there is a large defect in this tissue here, which we think is the patch. And you can see a lot of regurgitation coming from the outflow tract into the left atrium. A little bit more information before I go to 3D. So if I just use explain, what we immediately see is above the aortic valve prosthesis, you can see the tissue, you can see the struts of the valve, you can see the leaflets, you see the root here, but above it is that area that we saw, this blind ending patch that we talked, pouch that we talked about. And interestingly, it looks like there may be little threads of tissue here, so it may be loculated. But remember, this patient had quite a bad abscess. So as we move down, we follow it down. We've come to the level of the sewing ring now. But if I just move back slightly on that, let me just show you something else that's important, an important landmark. So as we move down, can you see, we can see the left main stem and we can see the circumflex and the LAD here. So what's interesting is that's quite low. So we're at the level of almost the sewing ring and the leaflets and the struts of the valve to where you see this. So that's an important bit of anatomy to be aware of. And as we move down, we're following this blind ending pouch down. We're going to keep following it down, and then you come into the outflow tract, and you can see here, this friable bit of tissue. We suspect that's a bit of suture that's come away, and it's probably come away from this end to the, away from the patch. And as it's torn, it's caused this defect that we've seen. There's a bit more though, because as we go further down and into the outflow tract, what's really interesting is as we enter the left ventricle now, you can see the cursor is here. This is what we're looking at. There is an area, a region here of the lateral wall that appears to be aneurysmal and thinned. And it's also causing a little bit of a sac. So let me just show you this on 3D. Hopefully I'll be able to do this live and demonstrate the anatomy. So you can see, here's the aortic root. AVR here, you can see that bit of suture flicking about just under there. So I'm going to move the picture a little bit. So what's amazing is, as you see the valve here, so if we look at it face on, if I'll rotate it a little bit like that, you can see where the sewing ring of the AVR is here. And what's interesting is, it's essentially, it's broken away from the patch here. Behind it, you can see that this patch it has this blind ending region, but actually it's quite extensive. It carries on around behind. So I'm going to lift the picture up. It carries on behind this region, and that's that region here in the lateral wall that's thinned and forming that sort of aneurysmal tissue. So there's the mitral prosthesis. Behind here is where the aorta would be, and the AVR is down here. So just to get your landmark. So this is looking into the left atrium, and you can see this is the defect that we were looking at. But what's interesting is if we put the color back on, not only are we seeing this defect, so here you can see it sideways. I hope you can appreciate LVOT through the hole into the left atrium. But not only have we got one hole, because when we did the TOE a few weeks ago, we only had one hole. Now, unfortunately, it looks like we've got a second one here. And I hope you can see that as well. And the measurements are coming out is for this measurement is about 11 by 7-8 millimeters, so relatively circular. And this is about 3-4 millimeters, but I'm going to do a little bit more measuring as we go along.
That's fantastic, which is superb echo. Okay, so we did a left coronary injection, and the eagle-eyed will be able to spot as we play through that both the proximal LAD and in particular the proximal circumflex have systolic compression. So that expansile sac that we have is definitely affecting both of those coronary arteries. Now, this morning, I had a repeat CT scan done, the last one being in December, and the pseudoaneurysm, this sac, has not changed in size at all, and that compression was also present without symptoms in his coronaries on that CT scan. So we'll hopefully be able to show you the CT scan. Next shot, please. So you can see again the circumflex compression is quite profound, the LAD less significant there. Keep on going. The right coronary artery is absolutely fine. So I think the demonstration of that is that we have the pseudoaneurysm, which may well close at the same time as we close the mouth of the paravalvular leak, but actually it's be quite important to be sure that we are looking at that pseudoaneurysm. I don't think I want to poke a wire into it to try and seal it off. I think it's got a very wide mouth, and I think that's not going to work. But as we treat the, can you orientate us, Bushra, on that echo? So go to echo. Okay, yeah. So if we go to echo, okay, so the aortic valve in that view is
at 12
o'clock.
Yeah, that's
okay.
right. Is this a surgical view? Yeah.
So this is a surgical view. So this is our standard clock face. So at 12 o'clock is the aorta, and that's where our hole will be. At 3 o'clock is the interatrial septum, which will be important in a second as we do a transeptal puncture. At 6 o'clock is as at posterior as we can go. And at 9 o'clock would be the left atrial appendage, which is up there. So, so in this view, the deficit, the defect, is where? So you can see that. And the second deficit?
Somewhere there.
Yeah, is a little bit further across.
It looks more like a paravalvular leak, but it's still within that patch, you know, where the outflow.
So you can see the major hole is clearly that one which is in the 12 o'clock position, which is exactly where you'd expect it to be.
Okay, so I'm going to mute it from there so we can maybe discuss. We'll let the video play, but you can say this is an extraordinary one-off case. And well, obviously, you can also guess how blessed I am to have Bushra doing the imaging with us. And if she's not available, then Nilesh also. So I'm blessed doubly. So I suppose the trick here was, I think the model, the 3D model I showed you, showed in red the extent of the pseudoaneurysm. It's about 5 centimeters at its mouth. So there's no way that was going to close. We thought we might be able to grab a mouth of it, but actually it's enormous. So this is always going to be about just closing the leak. So John, have you ever sort of seen a case like this?
Yeah, I have seen similar things in the congenital group. We see this sometimes after, you know, complex LV outflow tract work, Rosses and Conos, etc. But I mean, I agree with you, Iqbal. I think that all you can do is look after the leak. I don't think that you can do anything about this false aneurysm. I think you just have to hope that you can, that it will reduce in size if you deal with the ingress or the exit, I suppose, from it. Yeah, and I suppose the other trick, Shaq, I suppose the other trick here was that I'm now going to a transeptal puncture with a great big wobbly pseudoaneurysm sac close to where we're doing it. So again, the imaging is absolutely key. Any
2 or 3 cases I've done, not exactly the same, but similar with an aneurysm, false aneurysm underneath the aortic valve. We've approached them in order to traumatize them at least from a transapical view approach.
Yeah, so I think the surgeons were unkeen on operating. And to be honest, I know you're in favor of transapical. I didn't see that this was the chap that first off we'd have to go transapical. So I suppose a transeptal puncture, my technique was always use an SLO or an SRO sheath and a BRK sharp needle, and then have X-plane so that we can see exactly where we're puncturing. Especially important here because I think you can see on the panel we're not that far away from the pseudoaneurysm. And then if it's proving a bit sticky to push, then I get back my diathermy and about 30 watts cutting, and it just pops the needle through. Just touch the needle with it. You see the bubbles going across if you need to. It's a cheaper technique, I think, than using the specific RF needles, which I don't have easy access to. The EP guys use them sometimes. So we're doing the transeptal puncture. We'll then get the agilis in because I think, John, you made the very correct comment that it's almost impossible to do anything otherwise. I toyed with the idea of how to do it. So should we go antegrade or should we go retrograde? I was always going to want to use a sort of ability to snare and loop. And so I've done my transeptal puncture up front. But then it's a question of antegrade crossing and looping up into the aorta, or retrograde crossing and looping up into the aorta. I went for an idea that retrograde might be safer because I'd know where the aneurysm was and know where my wire was going and just focus on that, because you can't focus on all areas of the echo at the same time. Shaq and John, what would you do?
I'd go transeptal.
From the position, I think transeptal is fine. The aortic valve is a prosthetic one anyway, isn't it, or not?
No, it's a tissue valve.
Right. Okay.
Tissue.
Right.
And Shaq, can I ask, if you were doing transeptal, would you aim for a specific site on the fossa or just anywhere?
This needs to be well. I would have thought this needs to be more sort of superior puncture, really.
Yeah, superior and turned down maybe, but
Yeah.
I also fairly anterior. I find it always very difficult if I go too far away from the leak and arch all over the atrium to get enough control over it. So it's a reasonably anterior, it's obviously an anterior leak, and so try an anterior device. And so I tried all sorts of different catheters because I wanted to cross it this way and then snare, because and I think what you can see is that the wire starts getting closer and closer, then it starts going into the pseudoaneurysm. So we know we're even closer, and we're looking at both the fluoro and the X-plane echo at the same time. So we can see the wire getting closer and closer and closer, and eventually it does pop across, but it was a sort of a dart. You get your eye in, and then you dart it across. So we managed to get across, and then snare a loop to try and get a rail. And I did want to use, it's a large hole, and I wanted to use an Oculotech device. And I'm afraid we've been very complimentary about Oculotech up till now, but I'm going to say it's been about 2 years waiting for a sheath that's a reasonable length to do any sort of a proper leak closure from a retrograde approach, and they haven't coughed up. And this, I tried it with a 9 French sheath retrogradely, and it just wasn't long enough. So
yeah, sheath is a problem, isn't it?
It is a problem. So buddy wires, I must say, in a leak like this, complex, hard to cross, I always leave a buddy wire behind. Shaka, are you a buddy guy?
Yeah, I think that's reasonable in this sort of case, isn't it? Because you don't want to be poking around with wires having lost position.
Yeah, I would buddy it as well. And just coming back, adding to the sheath thing, I think it is a shame because as I say, I'm fond of the Oscar sheath, which is 12 French. And once you're across, you're then limited to a 9 French sheath in terms of what you can get through the Oscar sheath if you're using a rail, multiple sheaths through other sheaths, and that's not big enough for the largest Oculotech device. I think there is room for improvement in terms of the sheaths here for this procedure.
There is, in terms of length, the new DeVille sheath, which I think may well have an important role because you can get those in 12 and 14 French, and they're around 85 length, if not more. I can't remember.
Yeah, they are more, Shaq.
Yeah.
So basically, once we've snared the wire, then we've got a rail. I actually want to put a buddy in. So one thing I've sort of learned, I've done a couple of times now, is if I've got a difficult buddy to put in, then I put the TorqueView sheath up from the arterial circulation retrogradely and took the introducer out, put my buddy wire through that, and then pulled it out again and put it on the single wire that I wanted to use. So I still maintained my rail, but actually had the ability to put a second retrograde buddy wire in, ready for something extra to happen later. And if you pull everything out all the way from the leg, then having a Terumo or other wire next to your sheath doesn't cause too much oozing in the arterial circulation either. So I've snared it, creating a rail. I've jumped ahead in what my description was, and so once I've got the buddy wire and the rail, and I've deliberately looped the rail downwards into the LV to stop putting a strain on the aortic valve, then I've pulled my Agilis out and used the initial rail wire anterogradely now to get the Oculotech sheath into the left ventricle. It was a 9 or 10 French sheath that I put in, so I could use a fairly decent sized device. Bushra had measured the device, the whole size for us. So I think we're going to see the Oculotech sheath being pushed up now, and you can withdraw the sheath back, and as long as you're doing it slowly, even if you don't quite have the whole of the wire in your hand when you're pushing the sheath up, it tends to stay fairly still, so you can coax the sheath upwards without losing your wire position. So this is where I'm trying to now push from the arterial side to create a loop in the ventricle, because obviously there's an introducer which is a bit brutal, and the sheath which is a bit stiff. And I don't want that hammering the aortic valve, the tissue aortic valve. So,
which sheath is this that you're using?
What's that, sorry?
What sheath is that?
This is the Oculotech sheath now, because I want to use it. It's a 9 French sheath. And so I'm coaxing the wire down towards the apex. You can see it just moving down towards the apex so that I can get the sheath pointing in the right direction. And I must say, I don't use the wasted devices, the twist device very much. I use the wasted ones. And so you can here see a nice large rectangular device, which we're going to attach up and then try and deliver. And I think the point that was made earlier about can you see it, which orientation is it, comes out in this, because we do want to orientate the device in the right axis. And we'll see that the LV disc is quite hard to see, but the LA disc is actually very easy to see. It's because of all the shadowing that there is.
Now, what size did you select, or do you mention that later?
Yeah, no, it's coming up. I'm trying to remember. I think it was 14 by 5 or something bigger than the largest of the. I'll just find. Yeah, so there's a 9 French sheath, and then.
Any reason why you use the Ocular-Tech sheath and not, say, a flexor or something like that that will track a bit better?
I thought it was such a big hole that this sheath would actually not have a difficulty going through. And I used a 14 by 6 PLB, which was slightly oversized. But I suppose the difference between the Ocular-Tech devices and the AVP3s is that the overhang, the margins, are much, much larger. So the 14 by 6 is sort of 22 by 24 overhang. So it's a really big margin to cover things up with. So that's what I was trying to actually do. And I'm trying to demonstrate here the 2 dots. So you can either have a long axis or a short axis view. And on the waist of the device, in its mid segment, are 2 gold dots, which you can sort of see on the screen now. And you can use those to orientate. So if you can see both dots, the device is going into the page. And if you can only see 1 dot, then the device is going long ways across the page. Does that make sense, John? Did I explain that correctly?
Yeah, it does. I mean, the only other thing to say is that generally speaking, once you get into these holes, I usually find the device naturally will kind of funnel and correct its shape 9 times out of 10. So I think the concern of the device sitting in the wrong orientation in the defect is rarely the case in my experience, but I completely appreciate what you're doing, Iqbal.
Yeah, and I suppose the other thing here is that this is rather fragile tissue, so you can sometimes give prosthetic valves with a bit of a hole in, a bit of a yank, but I was very nervous about this particular patch.
Yeah, particularly as the patient had endocarditis as well in the past.
Yeah, so that was the origin of his whole condition. He got atrocious endocarditis, like he ate the middle of his heart up. And so the surgeons actually did all of that for his endocarditis. And after that, he didn't have any more. So I was trying to demonstrate what I'm trying to achieve. That's a nice diagram. So my thanks to Henry, our fellow who did that one. That's good. Okay, and then I'm trying to see whether I could catch it. So that device you can clearly see is nowhere near the hole. It's both discs are actually inside the left ventricular cavity. So we've recaptured and we're pulling up, and you can see the beauty of the 3D, which has caught a really lovely image showing that we haven't quite got to the right spot. And then we're sort of pulling up slowly to try and capture one side and then try and deliver the other.
I think the reason I want to space, sort of what we've all said at various points in this talking about this, is that this is completely driven by the 3D echo. If you don't have, these images are absolutely amazing, but you need them. With something of this complexity, you are really going to struggle, or even worse, you'll do harm if you don't have this sort of level of imaging.
You can't have her, John. I'm keeping Bushra.
No, I've got 2. I've got a good one too, so it's okay.
So the other thing with doing this anterogradely is that I find that these devices, there's quite a lot of tension on them, and I have pinged a few out. So you're very happy with your LV disc, and you're about to deploy your LA disc, and the thing just springs out. So that was the reason I wanted to start by going retrograde, because there's less of a ping. But this one didn't ping. In fact, it was big enough to hold in position. So we're trying to see if the disc is orientated correctly. This is the image where, maybe, possibly. Bushra, what do you think? Can you comment?
Yeah, I think, I easy on you at the time doing it because I'm flipping backwards and forwards through different views, but it looks like it's orientated quite nicely there to me along the length of the sewing ring. Oh, actually, no, we need 90 degrees, I think, turn. Now I've just
I think
orientated myself. Yeah, we need 90 degrees turn. Yeah, I think we decided at the time.
So I think we did eventually to make it turn to actually try and fit, and got a nice position eventually, but it was a little twisting around. Now, the advantage, I suppose, of Occlutech over the AVP3 is if you keep on turning the cable, you can't take this device off the cable because it's clamped. But if you get vigorous with turning the AVP3, you might unscrew the cable. So you have to just watch out for that. This one can't release until you've released the forceps.
So
the other one can release.
Just on that, did you, in order to twist it, did you push the left atrial disc out as well and then rotate? Or
So I think it can't rotate in the catheter very
absolutely.
easily.
But all the point I was trying to make was that there's no point, or very little point, in twisting the sheath. In order to rotate, it's better to push the device out and rotate.
I think if you're close, then you can rotate the sheath, but obviously that puts even more tension on a rather fragile septum.
Correct.
So I think if you can afford it.
The other thing to mention, Iqbal, is just how useful having the buddy is in this situation where you're trying to work with a very complex structure, not put too much tension, difficult orientation. You know, apart from anything, emotionally, it makes you feel a lot happier knowing you've got a buddy there in case things pop out.
Yeah, no, absolutely. I think the buddy is also there because sometimes you need more than one device, and so it's. I find the buddy very comforting. I agree. Working with a buddy, because Neil had said, working with a buddy is good, and having a buddy wire is also good.
The buddy can work against you because sometimes it doesn't allow the device to take its shape. Because the wire gets in the way.
Yeah, I tend to put a Terumo as a buddy, so it's pretty soft.
Can I just add one point about the imaging as well, actually, because we were really struggling halfway through to find, I was trying to follow you, but at the same time keep the landmark so we all knew where we were. And what's really nice is the multi-plane imaging, the simultaneous imaging. So if you can't see it in the view you're in, but you don't want to move out of there because you know you're going to need it in a second, the thing to do is use your X-plane and scroll along the image plane, and you'll find it in the orthogonal view, and you can still guide and orientate yourself. So that it was just being demonstrated there. So I just wanted to highlight that from the imaging.
Yeah, no, Bushra, the X-plane is absolutely amazing, and your technique of taking your line through different parts is really good. And so you can see that we were repositioning this device to actually try and get the orientation correct. To be honest, this rectangular device looks very square on 3D. We noticed that at the time as well, but it's just because the LV imaging is very, very difficult.
And so that's where the X-plane was really helpful, wasn't it? It looks in this image that it's actually lying lengthways.
Here it's about to turn. You can see. Actually,
you've just turned.
Can I convince you that that's turning?
Yeah, absolutely.
So you can turn it.
I'm not convinced.
You're not convinced? Oh, goodness gracious. Okay, well, we'll have to work harder. I'll have to do a better case next time. So we've got it eventually towards the spot. You can see the two dots. So on this picture, on the fluoro, the device is clearly going into the page because you can see the two dots pretty separated. And on the echo picture, it is now looking as though the rectangle is in the correct orientation, so along the edge of the mitral valve ring. So I think we were happy with this, and then trying to release the second disc without it pinging.
Yeah, and the disc is tilted on 3D. It's tilted away into the picture, which is why you can see that it's lengthways along the sewing ring, but it's actually tilted, which is why it looks a little bit square, which is why you just noticed I turned it just to check that.
This is a situation as well where having biplane can really help. I don't know if this is a single plane lab, but if you have two tubes, you can really sort of get a much better appreciation of the device on fluoro.
Yeah. So you can see the device is now coming right up against the edge, and we're trying to make sure that we can put both discs one either side of the that sort of patch. And we're about to see whether that's going to happen or not. I think the first time I did it, I got both discs onto the LV side of the patch, and then we had to do it again. But you could see very clearly on the echo, this beautiful X-plane, what was going to happen. So I think well, I kept all of this video in because it just shows that, you know, the delicacy of the operation and also the need for the imaging. If I was doing it all on fluoro, I wouldn't quite know what the hell was going on. But on the echo, it was actually very, very clear. And what I found was initially I thought I might catch the edge of the aortic valve as well and try and seal the mouth of this whole pseudoaneurysm. But subsequent to that, that 3D model shows that that was a 5 centimeter mouth, so that was never going to happen. We were just seeing one little bit of it. You can see both discs. I convinced you, John, that that is incorrect. So both discs were in the, a minute ago, both discs were on the one side, and here comes the correct position, about to open up. And that's caught that septum. And so the next part of the procedure now is to breathe aside the release of the device is sat there, and then it's over to Bushra to see whether that's enough work or more work is needed. And Bushra pointed out that there was a lot of tension on this device, so that the LA hat hasn't quite fully formed yet because we've got a cable stuck on it.
But also, what about the other wire, the buddy wire?
I think the other wire probably was, well, it certainly wasn't causing that hat appearance because it was well out of the way. But I think it could have been causing part of the leak. So here's a money shot where that device looks beautifully orientated, but you know, there's a dropout, or is there a hole? And then you put the color on, which Bush was about to do, and you see that you can actually see the wire coming out of that bit of the hole. Can you see that little extra wire that's coming over here? I don't know whether you can see that on my screen. So the other wire is coming through wherever that dropout is, and then we put some color on it, and you can see that in fact there's quite a lot of color coming out of that gap as well. So then we had a wire, and I thought, well, I just want to finish this procedure off, so we won't bother snaring and things again. What we'll do is we'll just use that TV2 sheath, a 7 French sheath, and they are beautiful sheaths. They seem to be coated, really slippery, seem to go through almost anything. And so put that up from the leg through the gap. It went through perfectly easily. There wasn't any pushing. And then think about another device. And so so that allowed us to get a second device in retrogradely this time to see if we could improve the situation. And I put the biggest thing in that I could, which was a 14 by 5 AVP3, which doesn't have the margins that are quite as big. This is 18 by 9 on the outside, the flanges, to see whether that would sit correctly or not. Because I think the hole's a whopper.
And the important thing to note there is it's a separate defect alongside the first device, and it's not through the device, just so people don't get confused and they understand the difference as well. So leaks through the device are fine. It's actually clear, discrete lesions around the edges that show you that you may need to do more.
Yeah, and so the AVP3 is definitely a softer device, and it comes through a much narrower cable, so you could probably get 2 or 3 devices through your one sheath if you wanted, one at a time, with just the cable coming through. The Occlutech cable is definitely much more braided and much thicker. You couldn't really get more than one through a sheath. And so loading it up, a quick flush, just to get a little bit more moisture through, make sure there's no huge bubbles. And I think if you have a TUI Borst or Y connector, when you're putting these up through the sheath, then you don't lose a pint of blood while you're doing all of this. So I've still got the other one attached. I've got the lid of the second device now coming through into the left atrium, and we're going to pull it down. And if you can do what I do in the lab with my eyes, is one eye on the fluoro and one eye on the echo. I need 3 eyes because there are 2 echoes to look at in X-plane. So using my 3 eyes, we can stare at what's going on and try and bring the device down to mesh up with the other one. So you can see the Bushra has now demonstrated that the lid of the AVP3 is now pushed pretty tight onto the left atrial surface of this gap. Okay, and then we're saying, is that a good orientation or not? Because that's clearly orientated in the line of the device. And now, if you wanted it to go 90 degrees to that, to try and fill a gap, rotating the cable is going to be unhelpful. I was now a bit unkeen on pushing and pulling and recapturing. So this is a sheath rotation that's going to happen just to make it go. It wouldn't go to 90 degrees very easily, but it went to about 30 degrees away from this to try and plug a bit more of that gap. So again, it's the orientation thing. I think I would have ideally wanted it to almost at 90 degrees to go and fill the rest of the gap, but it wasn't quite doing that.
It's not far off.
It's getting there. It's going to turn. You can just imagine it's turning a little bit now. It's certainly turned. Well, Shaq won't believe me, but I think it's turned about 30 degrees.
About 5.
5.
I believe you. I believe you.
You have to work with me. Shaq doesn't. So we turned it as much as I thought we could reasonably, and then it was saying, Bushra said, well, the leak has got significantly better, and it probably would get better again when that Occlutech device lid comes down properly, because it's being tugged at the moment. So which order to release? Who the hell knows? What would you do, John? Which one would you release first?
I don't think it matters too much, but I probably would let the Amplatzer go and then fold the back of the Occlutech once that's gone. But I don't honestly think it matters a great deal, Iqbal.
Yeah, no, I wanted to actually see what the ping would do, because the Amplatzer's softer, and I just wanted to get the Occlutech ping out of the way, because I didn't want the other thing to really change the orientation of the other device. So I fully deployed the AVP3 now. You can see on the fluoro that the LV side has happened, and this was important because the V wave pre us putting these two devices in was about 70 to 80. Just incredible, 70 to 80 V wave at the left atrium, and it went down to about 45 with the closure, and so that made, and the blood pressure, systolic blood pressure, as you can see, was about the same. So it was a really dramatic effect on his pressure, and so I thought, well, do I want to be chasing then the next leak? Because if those two are at sort of 12 o'clock, then about 11 o'clock, 10 o'clock, there is another leak. And so it's taken a while to get to this stage. So we're about to release. Bushra captures the release of this Occlutech device, which is a lovely thing to watch. So it's about, you'll notice it when it happens. We're still fiddling about. So when it happens, it sort of, the lid just suddenly sits down properly. Obviously, all done with a bit of care and with making sure Bushra is happy. The main technique in any of these parallel leaks to make sure whoever's doing the echo is completely satisfied with the result, because they tend to be more critical than the interventionalists who go, oh, it looks all right.
You can see the device is now orientating itself a little better as well, isn't it? Just as we're sitting there,
yeah.
The Amplatzer.
So you can see
he hasn't done anything to it.
Well, it just looks like it's settling in better to me, just from its position.
Well, I think it's. I think it looks the same as it did on the pictures because we haven't done anything. You're absolutely right, Shaq. But the angle went upwards compared to where we started out. So you can see where the LA disc easy to see. The LV discs, a little bit more of an eye of faith. Bushra did try and point out to me where the two devices were. But you can see it's much harder to be absolutely certain. I think one of the devices is just about visible, again up at that 12 o'clock position. The second one was, Bushra said she could see it, didn't you, Bushra? I said, I'm not convinced that I can see it. I know it's there.
Yeah, you can see the attachment. You can see the kind of the cable in this, its kind of central pin on the other one, but not clearly. I don't think I can see them clearly, but I can.
That's part of the point I was trying to make earlier on about the view from LV.
Yeah, and I would have loved to have gone into the deep transgastrics to look at this, but there's no time because we're looking at the other side. That's more important. So.
Yeah, so I think we're about to release. I think we're satisfied that that looks okay. And we're just checking so that leak, that jet is the other jet. Yeah, Bushra, so we just see a flash of the other jet, which is nothing to do with these devices. There's a little bit of leak in between the two devices, but these haven't had time to endothelialize in the 10 minutes we've been doing it. So I think we deliberately left the second leak alone, which, as Bushra rotates her hand, will sort of occasionally emerge. That one's through the device. And then as she turns her hand, you see a jet that's underneath it, which is completely separate. I think we're about to ping it. There we go. So you can see that it really changed its orientation just to get the lid to sit down flat. Thankfully, it didn't fly off.
Yeah, convinced about that one.
Okay, so I think we then release the other device and do some final checks. I didn't close the ASD I'd created. It was they always sit like these ASDs, so I didn't close that. Who knows? His left atrial pressure may have benefited from having a pseudo AFR device hole left behind as well. But he's actually done spectacularly well. So the plan was always to bring him back and close the second leak, but he's told me that he works as a painter and decorator. He's gone back to work because remember, even during lockdown, painters and decorators are doing quite well. So he's gone back to work and he says, oh, fine, I don't climb up the highest ladders, but I can actually do everything that I need to do. My symptoms have disappeared. He's had one more CT scan, which shows that his pseudoaneurysm remains exactly the same. That hasn't changed at all, which is comforting because I don't think I can do anything about it anyway, and the surgeons don't want to operate. So we haven't actually brought him back to tidy up the other leak because there's no hemolysis. His symptoms are better. And I don't think it'd be a particularly low risk procedure to sort of fiddle about close to that mitral valve ring. You're going to have to sort of go over the top of the other devices to get to the sort of 10, 11 o'clock leak.
But also that leak, it's hidden around, in that sort of that aneurysmal region. So it'll be tricky to get inside and then maybe cross and get your stability, I would have thought. But I'm sure we'd have a go if it was appropriate.
Made a big deal about getting good results for these patients. This is an incredibly complicated and complex patient with a lot going on here, guys. And I think you've done a very, very good job with what is a very tricky set of holes and an aneurysm. And there is downside to going back. It's not a freebie going in and trying to deal with whatever's left. So I think in the presence of falling V-wave, improved symptoms and no hemolysis, you've got to think very carefully about whether it's necessary to go back in and start hunting for that other hole.
Brilliant. Yeah, it's a brilliant case. I wouldn't. I would rely more on patient symptoms rather than go chasing.
Yeah, I would add to that actually, because in the past, we started doing these cases, we'd be there for hours and you'd still want to hunt for that other defect or whatever. Then you realize actually, you know what, it's actually safer to stop. You'd end up having all these complications, particularly from the groin side as well, the longer the case went on for and the more you fiddled. So it gets easier now to stop and say, no, we'll stage it. We'll see how the patient gets on. And often you're surprised at how well they've done.
Yeah, I mean, I think it's horses for courses. I mean, this guy, big hole and a smaller hole, we stopped at the big hole. And then I did one 2 weeks ago where there was a big hole and a smaller hole, and the man came all the way from Plymouth to say hello to me. And I thought trying to get him back again would be almost impossible. And it'd been a bit quicker to do it, so we did it all. I think you have to choose your patient. For this guy, I think the right move was just to stop. And in fact, we seem to have permanently stopped because he's fine.
Yeah,
good.
No, I think that's superb. That's a brilliant finish, isn't it, to this webinar? Thank you very much, Iqbal and Bushra in particular, for those superb images. I wish we got that quality in everywhere else as well.
Very offensive to Saliha, I have to say. I'm sure she's absolutely brilliant. We've seen some of her pictures as well.
Well, no, she is, but just saying how wonderful Bushra is in making your job easier.
Thank you, Shaq. Tell Iqbal that regularly, won't you?
Oh, I will make a point of that. Yes.
This part of this session's concerned, we should wrap that up and thank everybody that spoke and obviously you guys for that fantastic case. And then I'll hand back over to the directors and the organisers for the finish up of the event. Thank you very much.
Right. Thank you very much, John. I think Mark is probably still busy, isn't he? I don't think he's come back, but on his behalf, and I'll get Iqbal to say a few words as well. We've had a wonderful day with all the speakers, the panelists that have been involved in giving some superb lectures. And we've had some interesting questions from the attendees as well. We've had good attendance, which has stayed from start to finish. So thank everybody from us, from myself, Iqbal and Mark. And I want to thank Voxley Tech for their educational grant for this. We hope this has been a really good educational event. We've covered quite a few areas. And now I hope that you all keep safe for another few months from the COVID. Iqbal, last words, and then we'll pass on to Shaq and Margot.
Lovely. So I'd like to thank the CSI crew as well. So Inga, Magda and Denise, who've been burrowing away in the background and actually made the IT seem pretty good here, despite all of us Philistines who work in medicine who can't quite work the IT properly. So thank you very much for that support. Thanks to Margot for getting it sorted out, and Shaq, who I suspect has some of the purse strings. So I'll hand over to you two. Thank you so much.
Thank you very much, guys. Appreciate all the support that's been given by the directors. Obviously, always happy to see you and the rest of the team. And obviously, we're always here to help whatever we can, COVID, pandemic, whatever. We will still go out there and still help with your patients as always. Margot, over to you. Anything you got to add?
Yeah, I second everything that Shaq has said, and we'll send you your certificates individually with your CPD code on Monday. And yeah, I would really appreciate you filling out the feedback form that will be sent to you as well via email. And that's it, really. Thank you.
And fingers crossed next year we can all be together.
Yes.
Margot and Shaq, thank you very much. This is amazing. We're only 3 minutes behind time. This is unusual. Inga, last word, very last word to you.
I can only just second what everyone else has said. Thank you, everyone, for joining us, and stay safe, and see you soon. Thanks, everyone.
Bye now.
Thank you, Inga, for everything.
Thank you, and bye-bye.
Magda, bye.